Good morning. Good morning, Charles. Thank you so much for that lovely presentation. And I'm Wendy Stock. I'm a professor of medicine at the University of Chicago, and I have the pleasure of talking to all of you about immunotherapies and which ones are available for treatment of ALL. So now I hope to introduce you and follow up on Dr. Mullighan's presentation to talk a little bit about some of the specific therapies that are currently available and approved for treatment of ALL that are immune-based. There are 5 immunotherapies currently approved in the United States and in the EU for B-cell precursor ALL. And they include, as you see here on this side, antibody drug conjugates. One of them is inotuzumab ozogamicin, bispecific antibodies or BiTEs, and the one that is currently approved is blinatumomab. And there are a number of CAR T-cell therapies that are approved. And as Dr. Mullighan mentioned, some are approved for adults, some are approved for children. And they include these 3 products listed here. And we'll talk a little bit about each of these. Next slide, please. The antibody drug conjugates we'll talk about first. Next slide, please. The one that is currently approved is inotuzumab ozogamicin. Inotuzumab, I'm just going to call it inotuzumab for simplicity's sake, is a typical antibody drug conjugate, and it's made up of 2 parts held together by a link, as you can see on this slide. It has an antibody, lab-made protein, which helps to guide the treatment, as Dr. Mullighan presented, directly to the cancer cell. And then, once the antibody is attached to the cancer cell, a chemotherapy drug, in this case, a drug called calicheamicin, is released only when it gets bound to the cancer cell and gets released into the cancer cell. In inotuzumab ozogamicin's case, the antibody recognizes a protein called CD22. And because of this very specific attachment and injection of the chemotherapy drug into the leukemia cell, it prevents the toxicity that would be too great if the chemotherapy drug was given alone just into the body. This delivers a very specific target to the leukemia cell. The link that holds the antibody and chemotherapy drug is what binds the molecule to the cell and to each other. And then once the antibody is bound to the cell, it is released, the chemotherapy drug, into the cell. The mechanism of action, therefore, assures that the toxic effects of the chemotherapy are focused truly on the cancer cell and avoids exposure to healthy cells. Next slide. Who might be eligible to receive inotuzumab ozogamicin? In the United States, it's approved for adult and pediatric patients over the age 1 year or older. And of course, in order to be effective, the leukemia cells have to have on their surface the CD22 protein. In the EU and the European Commission, it's approved for adult patients with CD22 relapsed refractory BALL, and also for adult patients with Philadelphia chromosome positive BALL who have actually failed treatment with another form of treatment, a tyrosine kinase inhibitor. There are a number of areas of interest with inotuzumab. That is, there are a number of trials that have incorporated and have tested the ability to incorporate inotuzumab into earlier lines of treatment, including the initial treatment of ALL, BiTEs, and the one that is approved, next slide, please, is blinatumomab. BiTEs, as Dr. Mullighan already described, are made of 2 linked parts, one that binds to the cancer cells directly, and the other that binds to the immune cells, bringing the 2 cells together and allowing the patient's own immune cells to kill the cancer cell. So blinatumomab acts like a bridge, and it binds to CD19, which is found on the surface of the vast majority of B-cell leukemia cells. And the other part of the antibody of the BiTE is binds to a molecule called CD3, which is found on the surface of T cells and are part of our own immune systems. And therefore, this means that in this case, the patient's immune system is guided straight to the cancer and facilitates killing of the leukemia cells. Again, similar in scope to the inotuzumab, which kills the cancer cells, but spares, in large part, normal healthy cells. Next slide. Who might be eligible to receive blinatumomab? Slightly different recommendations in the US and in Europe. But in general, blinatumomab is approved for both adult and pediatric patients older than 1 month of age. And it can be used in first or second complete remission, that is in patients with MRD positive disease. In the United States, it's also approved for patients with relapsed refractory disease that expresses CD19. In the EU, there are similar approvals, and it is approved also for patients with pH negative disease and pH negative precursor BALL as part of post-remission therapy. There are a number of areas of active interest with blinatumomab. I just mentioned that it is already being used in earlier lines of treatment, including in the frontline therapy, and it runs continuously 28 days in a row, 24 hours a day. The patients usually wear an infusion pump that allows the patient to go home. Next slide, please. There are a number of side effects that occur with blinatumomab, and they include fevers, blood pressure changes, and some changes in blood counts and in the liver enzymes. Next slide, please. The last group of immunotherapies that I'd like to talk about are the CAR T cell therapies. Next slide. As Dr. Mullighan mentioned, these are reprogrammed immune cells, and you can see that different products are approved in adults and children in the United States and in EU. There are a number of very active interests for research with CAR T cells, including using the CAR T cells earlier in therapy when patients have not relapsed. There are ideas to combine two different targets, two different proteins that the CAR T cells can identify. CAR T cells are associated with very unique toxicities, and they can be very dramatic. The CAR T cells are infused after patients receive some chemotherapy to prepare their immune systems to receive these CAR T cells. And so you get a few days of chemotherapy, the CAR T cells are then infused, and within days, usually, patients can experience very severe, sometimes toxicities, including fever, confusion, and other immune reactions. And sometimes long-term follow-up is needed, and patients need to be hospitalized during these initial days of treatment, and then for close follow-up following the infusion of the CAR T cells. Next slide, please. The 3 CAR T cell products, as I mentioned, are associated with frequent side effects that occur in a large number of these patients. One of the unique toxicities for CAR T cells is what is called the cytokine release syndrome, and also neurologic toxicities where patients can experience confusion, sometimes even more serious neurologic toxicities, including seizure and significant mental status changes. Next slide, please. Future directions. I'd like to mention a few things that are going on. in the world of ALL. It's a very exciting time. As I mentioned, we're working on immunotherapies for T-cell ALL. And also, because these cells need to be manufactured, and sometimes patients are in urgent need of rapid treatment, there are new techniques being developed to engineer these T cells in a much more rapid fashion. Currently, it takes 2 to 4 weeks to make these cells, and there are new methods being developed to engineer cells more quickly and to also use more prepared T cells, not from the patient themselves, but from donors. Also, one of the areas of active interest, as we've already mentioned, is trying to use this form of immunotherapy earlier in treatment before the patient has relapsed. Next slide. So, a little bit of take-home knowledge. The 3 treatments that we've talked about: antibody-drug conjugates, bispecific T-cell engagers, and CAR T-cell therapies, all of which are very effective and unique methods for targeting cancer cells using different aspects of the immune system. Currently, as I mentioned, immunotherapies are approved exclusively for B-ALL, but a lot of work is ongoing in T-ALL. And we're also working on thinking about how to introduce safely and effectively these treatments into the front line of therapy. Thank you so much. Would we like me to deal with this question or later? James.
I think, given that it pertains to the things you've been talking about, probably, I think now would be a good time if you've got a little bit of insight.
Okay. There's a question that says, most immunotherapies focused on their use for B-ALL, and what is their application for T-ALL, which is a more aggressive form? T-ALL is not necessarily a more aggressive form of ALL, but unfortunately, because of the way that these antibodies were developed, they have so far been developed for patients with B-ALL. And there are a number of reasons for that, in that that we can talk about potentially later in the conversation. It's just a more challenging thing to develop T cells that recognize the patient's own T cells without causing significant damage to the product that's being infused. And so there's still a lot of work going on where antibodies are being targeted to proteins that are on the surface of T cells and seeing whether they can be effective in the future. There is one that is being tested right now called daratumumab, which is an approved drug for other diseases in the blood cancers that targets a protein called CD38. And there are a number of CAR T cells that are being developed for patients with T-ALL that identify proteins and target proteins like CD7, CD3 that are present on the surface of the T cell.
Amazing. Thank you, Wendy.